As we begin the transition to our final panel, I like the word, it's not a matter of if, it's just a matter of when. That could be applied to a lot of things.
All right, we'll go ahead and get started then. Good afternoon, everybody. My name is Jamie Sowers. I'm the Deputy Communications Director for the Agency for Healthcare Administration. And we've already heard a little bit about today about the state of the state, the current environment, and the current health IT landscape here in Florida. We followed that up with our recent panel about some security considerations and some HIPAA provisions. And what we're going to try to do here with this final panel is tie that all together. And what we really want to do is we want to take all of this knowledge and theory and policy, and we want to convert that into what actually happens on the ground, what actually needs to be done to practically apply what's going on in the health IT world, and specifically, what are some of the challenges and some of the benefits that are being incurred by the providers, the health plans, and the other types of treatment professionals there on the ground. So we're going to be asking our panelists to discuss their opinions and their observations on the costs. Specifically, we know that there's a financial cost associated with standing these systems up. There's some additional costs, some secondary costs, the time invested, the human resources. You're going to have to train folks to use these systems. So what's going on out there, and how can we mitigate or minimize those costs and make it as easy as possible to get these things online? And then finally, we're going to talk about some of the benefits of these systems, specifically to the patient in the form of better health outcomes, and some more operational efficiencies for the associations and organizations that are putting these in place. So first, I'll introduce our panel. On the far side there, we have Dr. Larry Deeb, who's currently serving as the director for the Diabetes Center at Tallahassee Memorial Hospital here just across town. Dr. Deeb is also a clinical professor of pediatrics at the University of Florida and a clinical professor in pediatrics and behavioral and social medicine here at Florida State. Next to Dr. Deeb, we have Dr. Paul Glisson, who you heard the keynote presentation, very entertaining earlier this morning. He's currently serving as the Quality Physician Advisor and the Chief Medical Informatics Officer at Baptist Healthcare in Pensacola. To Dr. Glisson's left, we have Mr. Evan Carter. He's the Director of Health Information Systems at Audacious Inquiry, an information policy and technology company focused on making healthcare smarter. And finally, closest to me, we have Dr. Gregory Preston, the Chief Medical Officer for Integral Quality Care, which is a nonprofit provider service network based in Tampa, Florida. So, gentlemen, thank you for being here with us this afternoon. If I could open up the discussion, Mr. Carter, we'll start with you if you don't mind. Could you give us a brief overview? We heard about the Florida Health Information Exchange from Secretary Dudek this morning, and particularly one of the services offered. I was hoping you might be able to cover the other services offered through the exchange here in Florida, and specifically how they allow for better coordination of care and provide better outcomes for patients.
Certainly. The tools are there today for, near seamless care transitions and coordination. It's just a matter of, if I could snap my fingers and have everybody in the state using them, that'd be fantastic. But that's unfortunately not something we can do. But like I said, the tools are there. You got the proactive tool, which is the event notification system, and it's coupled with the reactive tool, which is the patient portal. And the idea being, if your health plan, you get an encounter notification saying that one of your members was admitted to a hospital or discharged, and you can then follow up with that patient to make sure they get into their primary care physician, specialist, whatever the need may be, in a timely fashion, and to close that loop and to make sure that discharge instructions are followed and that unnecessary readmissions are avoided. That is, that's the ultimate goal. And then once that is scheduled, once that follow-up visit is scheduled, then the provider can log in to the portal, to the patient lookup service, and get the longitudinal record for that patient, which of course will include presumably the discharge summary from that hospital visit. And so there's no questions, there's no gaps. The physician knows exactly what the patient needs to do to avoid follow-ups. There's with the query portal, the patient lookup service, there's the hybrid offerings that are going on in Pensacola and Tampa, and don't let the geography there throw you. That's something that every provider can log in and get to without an EMR, without any really robust technical infrastructure in place within their practice and get that data. And you know, fortunately, right now with the way E&S is set up, the health plans are doing the legwork to get you that data, to get the patient in the door for you, and then all you have to do is have an internet connection to log in and get the necessary discharge summary. So I mean, I really, the tools are there. There's just a lot of ground to cover. It's a big state.
Absolutely. Dr. Glisson, you talked a little bit this morning about electronic health records, electronic medical records, and I'm just curious, your opinion, what's fueling the transition to EHR and to these digital formats of storing patient data, and also some ways that providers are using them to provide better care for their patients?
Well, I think the move to EHRs is basically dividing us into the haves and the have-nots. There's two camps. There are those physicians who are affiliated with larger healthcare systems, and there are independent. So the ones that are independent are there are problems, right? They're the ones that are still on paper, or they're the ones that are still kind of doing things like the wild, wild west. So hospital systems, for instance, like the one I work with, offer to supplement and help physicians get on board. And just ask yourself, how bad could the program be if a hospital offered to pay 75%, which is the maximum under Stark Law, 75% of your costs for an EHR, and you said, I'm good. That's what's happening. So that's how bad the systems are and how much resistance there is for the independent physicians to use them. The ones that are employed physicians, they're taking, that's why they probably became employed, because all these things will be taken care of as far as EHR and their billing and that kind of stuff, contracting, that kind of stuff. One thing I'll mention, though, we really haven't talked about it here, and it's something that we should be talking about a lot, is the SGR fix from April. So if you guys have not reviewed this, it's something that it's groundbreaking, it's more important than what the Supreme Court was talking about yesterday. It's really going to change the way we practice medicine in America. So the SGR fix was much more than just changing this sustained growth rate for Medicare. You know, it was set to go down 21% in May of this year, and Congress stepped in to stop that. But what they really did is they put in two different pathways for physicians to practice medicine in the future, and this all starts in 2019. Basically, there's going to be the old fee-for-service, which they call the MIPS, which is it's their provider, it's incentive payment program based on basically fee-for-service, the old fee-for-service program. So you can continue that, and you're going to have bonuses. You know, your Medicare reimbursement is going to go up 0.25% per year until 2026. Or you can join this alternate pathway, which they call the advanced payment model, which basically says you're going to take on risk. And they are forcing providers by 2019, they want to have 25% of your patients in some kind of a risk payment program. By 2021, they want to be 50%, and by 2023, they want 75% of your patients to be in some kind of a risk model. So I don't think physicians have got it yet. They looked at it, oh good, well our SGR is going away. What they don't realize is that no, the law has been written that you cannot get to where you need to be by 2019 unless you have an EHR. You can't do this manually on paper. You can't present these things. So also as part of that, so no matter what system or pathway you choose, meaningful use goes away, right, in 2019. So in part of the fee-for-service track, they're now going to combine your PQS payments with your meaningful use incentive payments with your value-based purchasing, your CG caps that come through physician ambulatory practices. They're going to bind all that into one composite score. So basically, if you don't have the EHR, I mean, you're going to take a significant hit as far, because your meaningful use reimbursements are tied to that too. So significant changes are coming. I think as this settles in and people realize what happened with the SGR law or the SGR fix law coming in place, that they're going to realize that EHRs are going to have to be there's going to be mandatory. I don't think there'll be much paper left after 2019. So that's what I think is driving. Obviously, meaningful use got us to where we are right now, but the SGR fix is going to push it up and seal the deal.
Sure. And maybe some of the providers on our panel could talk about how EHRs are being used to benefit the patient in the form of better outcomes and a better overall experience. Did anybody have any input on that part?
Yeah, I think that certainly in my practice, being able to interact in ways that you never could in the past. And so these interesting, I'm in solo private practice, and I've had an EHR since 2009 or 10. And, the patient portal becomes a secure email system, and we write back and forth. And I'm comfortable using it because they can access their own information, and I can freely say things back to them. And I think certainly being able to talk to people when it occurs to them and when you are available. That's the other detail. It's not a phone call interrupting you. Is going to, at the end of the day, help people take better care of themselves. And I pray that Florida comes up with a meaningful ability to go to telehealth, because I take care of lots of chronic medical problems that really could see me once a year if I could interact with them and still keep my office open.
Okay. Dr. Preston, did you have anything to add to that?
Well, I'd just like to tell this one story. I was in the urgent care clinic at 10 o'clock on Friday evening, pediatric clinic, and a 2-month-old was brought in at the very end of the day with a fever. Looked healthy, nice baby, good family, but I had 2 choices. Fortunately, we were on an electronic health record and integrated delivery system, and I found the baby's primary care doctor and was able to call him and say, I can't find anything, he looks really good. And he said, I've got clinic hours tomorrow morning, have him come to the clinic at 8 and I'll look at him and decide. The alternative, which Paul will tell you, would be to send him to the ER where he'd get a blood culture, spinal tap, x-ray, labs, and be admitted on IV antibiotics till Monday morning. I mean, the electronic health record's fantastic.
Okay. So I'm hearing a lot of benefits here, both for the provider and the patient. So I'm hearing that there's more open lines of communication, and interestingly, it seems like this is getting patients more involved in their own care, which I think is something that we might have missed out on a little bit in the past. And also, it's reducing those duplicative services that may not be necessary to replicate when you move from one level of care to another. But Dr. Glisson, you mentioned that really when it comes to EHR, we're divided into the haves and the have-nots. And so that ties in nicely to our next question, which I'll open up to the entire panel. How are HIT services and programs working to make this technology more available to those that don't have the resources that some of those larger health systems do? What kind of programs or assistance is out there to get some of these smaller practices onboarded and using these types of services?
I'd be happy.
It's up to you.
He threw it at you.
Well, I know our county medical societies have a big HIT forum that helps physicians come together and get some advice from the group. A lot of times group think is a lot better than solo think. So, for instance, our Escambia County Health Department there moderates a lot of that there to kind of give them some advice. And we have done a lot of outreach to explain what the benefits are of sharing data back and forth and getting them on board with our HIE Direct model. So it's not, the cost is minimal for physicians to get signed up where they can actually do a web request and get the CCD sent back. So that's kind of how we're reaching out to them to get involved. And I think a lot of physicians come on staff still they join the staff even though they don't admit patients anymore, but they do that just to get the HIT resources that are involved with that. So they get access to our portal, they can see our x-rays, that kind of stuff there. So we have a special category for credentialing now that allows physicians just to be basically consulting base where they don't admit patients, but they have access to all our information there. So, but I think physicians find that you can't really live as solo anymore because lab systems now, HealthQuest and LabCorp, they're all internet based and they're feeding right in direct into EHRs. So is the cancer registry, so is different pharmacies with SureScripts. So those things are all putting pressure on them to get involved and helping them along.
Sure, and I think that's the perfect tie-in maybe to our next question, which is what are the challenges and what are the requirements of not only providers but also health plans and other levels of care in integrating these multiple EHR systems and getting them all to communicate together when you have numerous independent providers and then you also have the health systems that they're members of? How do you get all these systems tying together and not necessarily like conflict with their messaging and the different channels that they're communicating with you through?
Well, again, I'll say that Blue Cross, and so that's what I deal with mostly because we have a Blue Cross ACO plan. they know more information. I mean, they know when my wife misses her period. They're calling me saying, "Hey, there's some baby shoes for you. You know, if you looked at these kind of things." So it's. I'm like, what? This is crazy how much information they know, and they give it to us every month. And most systems probably just ignore this stuff. So, health system. I mean, the payers are really invested in this. Their problem, though, is making it actionable, and I think that's what they're putting on the healthcare systems. Okay, here's this big dump of data. Now, what do you do with it? We expect you to make these great decisions and keep patients a lot healthier based on this data, but they're not really jumping forth and telling me how that's going to happen. That's more my kind of job. So, sure.
I think it ties into the question you asked previously, and the haves and the have-nots. There were, and again at the outset of this whole HIE movement, there's an idea that EMRs are a prerequisite, and you're going to be doing continuity of care documents. That's what you're going to be exchanging, and everybody has to have one of those, and everybody has to be able to send one of those. And and there's a lot that came out that helped perpetuate that misconception. But I think as we've realized that meaningful use didn't make the have-nots go away. You need to scale back, and you do have all these disparate systems, and people, there's still, what is a CCD? There's a lot of that still going on. So you scale back, and that's when a service like the event notification system comes in. Instead of this incredibly complicated continuity of care document that a lot of people can generate and can use, and it's immensely valuable for them, but a lot of people can't. Let's go to the ADT message, the admit, discharge, and transfer message, which is the binary code equivalent for health information, and it's something that everybody can transmit, everybody can use. It's actionable, and you only need an internet connection to get in and get that information and act on it. And it's it's the easiest use case to articulate in the world, because you get it, you call the patient, you get them into the office. So between things like the HIE direct service that's going on in Pensacola, where again all you need is an internet connection, and we're doing really simple, really manageable pieces of data that are highly actionable. We're getting to more practical applications. Imagine that. So it's been great to kind of watch that progression to really have folks find out what works.
Sure.
And well, the volume is the problem. For payers, we have scads of data. In our plan, we don't just have claims data. We get data from different sources and pour it in the same data mart so that we can generate reports. But there's so much information that if you give it to a physician, it's useless. So you need to be able to answer questions, and everybody's trying to give them information. In the old days when we sent everything in paper, I always think about this doctor showing up at his office on a Monday morning to open his practice, and there's police tape around it in a coroner's wagon, and the doctor says, "I got to get in there. My patients are coming pretty soon." And the investigator says, "You can't. There's been a death in your clinic." And the doctor says, "What do you mean?" He says, "All that information that all the health plans send you that you put on your desk? Well, the pile fell over and killed the person who was in here last night cleaning your office." Well, it's no different. Digital is no different. How do you make it useful?
Sure. And are there some specific requirements, Dr. Preston, maybe you can comment from the perspective of a health plan and a provider service network. Are there specific requirements from the individual providers to get tied into your systems to start communicating? What are the heavy lifts that are taking place there?
Well, the heavy lifts are two. One is creating the interface, and that's really not very difficult because now you can build portals that give people all their information. Right. But the other is, like I said, everybody is trying to generate interest in their data. So how many websites do you want to go to find information about your patients? Right. And proactively, how do you want to do it? Doctors are still reactive. They see people when they show up in their offices. They don't sit there from 8 till midnight every night trying to figure out who's going to be there tomorrow, collect information about them so that they're prepared for the next day. They do what they do every day, and there's not enough time, there's not enough technology. Maybe we should be preparing the patients instead of the doctors to come in with their information.
Okay, so we're talking a little bit about how do we communicate from the provider level up to maybe all the different health plans that their patients are members at. What about on the same level? How does a primary care physician communicate with a specialist or maybe with the local hospital when their patient's hopping around from one facility to another? And what kind of challenges are there, or what can you do to minimize the difficulties, the friction?
Well, some of the big payers are now looking at the technology that integrates that, so they're providing the downloadable, free, thin technology that will allow providers who are willing to subscribe to it to communicate from site to site to site. And everybody's competing because they want people to participate in their networks and see their insured patients or their insured members, but as long as it's more than one technology, as long as you have to go to different sites, the problem is going to be, I think the people like Evan and other people who are building this need to bring it all in and then feed it back. If I have to go to, so I have, the average physician probably has 18 or 20 contracts. And if I have to look at 18 or 20 different communications, I'm just not going to bother.
Right. From the ER, I can tell you that patients are starting to become savvy as far as they're getting health care from different places. We first started seeing this with CDs that had their x-rays, right? So they go to the urgent care, get an x-ray, they put it on a CD and bring it to us. So that helps them bridge the gap between getting care back and forth now. And I've seen my first couple patients now that have come and brought a thumb drive with their CCDA on it. And I was embarrassed because, I don't know where to put that. But, I'll stick it in the computer. But actually, we got it off and imported it in. But, until someone asked that, I got a class on how we do that. But until you've done it a couple of times, you don't really know how to do it. So these patients are pretty savvy. I actually, right now, still dealing with a patient who asked for their CCDA so they could take it to their doctor on a thumb drive, and I gave it to them, and they actually reviewed it while they were in the emergency department there and disagreed with my diagnoses. So then I had to go, I kept trying to say, well, it's my diagnosis, it's not yours. I'm like, no, it's the patient's like, it's my diagnosis. I'm like, no, it's my diagnosis, I'm telling you. So we had, evidently there's some ambiguity in the word substance abuse. So I don't know. We're looking into it. Maybe ICD-10 will fix that for us. I don't know, but anyway. Anyway, we'll leave it at that. So, so patients are going to get smarter and savvier with this, and we're going to debate all this stuff because it's all out in the open. They're going to see all that. So, in Pensacola, we have a big problem with that, though, because the Pensacola Naval Hospital is there, and they have no cardiologist on staff there that do anything. Like they can't do caths and echoes and stuff at the Navy base, so they send them to Baptist Healthcare to get it done. So, no matter what, there's always some kind of continuity of care issue because they're leaving from a DoD system, which they don't play well with others, to us, and then they want to get everything back, and then so how do we make that work? So right now it's all on paper and doing a lot of faxing, but it's kind of embarrassing that we have so many fax machines still going. And that's the true test of when the EHR is working, is when there's nowhere to get fax toner because we just stopped making fax machines. So you get those out of the office and you'll know that we're actually are interconnected and sharing information back and forth. So
sure.
Good point. The three pieces of information that you need to make a quick decision are the demographics, the disposition of the episode of care, and the diagnosis. Right now with ENS, we get two of those, and they're really great. My experience is, because I used to go to hospitals and beg to get lists of my members in my health plan who showed up in the ER the night before, so that I could parse them out and decide who I'm going to call and who I'm not. Because for the health plan, it's volume. So I have 90,000 members. I have it's a relatively small health plan. But I get about 500 hits a day on the ENS. So, that's a lot of calls to make. About 200 of those are ER visits. And the 500 is duplicates because you get admission and discharge. So I know they were in the hospital, they were out of the hospital, they were in the ER, they were out of the ER. What I do get from that is a phone number, and in Medicaid, you might not understand how valuable the phone number is and the contact information. And Medicaid clients give their real phone number in the emergency room, so that's a very valuable piece of information.
Because we're choking it out.
The one that you can call the next day, and they'll actually answer the phone. The disposition we know who stayed and who went. We also, the only thing we don't have right now is this diagnosis, and I've been talking to Evan about how vital that is, because right now with 200 ER visits a day, I have a small staff who does outbound calls. The only way I can decide who to call is to take just everybody who's there between 8 a.m. and 5 p.m. and assume they probably shouldn't have been there. And I get a lot of fractures and accidents and reasons for people to be there, but otherwise I would never be able to call all these people. Same with the hospital. I would love to know who was there just for a delivery, because I can tell you in managed care we don't deny hospital admissions for deliveries. And we also know that the baby's born so that we can follow up with the baby, because we might not know that baby for 3 or 4 months after he's born. And this baby might go to the NICU, they might have some problems that they need. We'd like them to make their first primary care visit, because we know that that's going to avoid problems down the line. So what we do now is we identify special populations who are in case management or disease management or some other segment of our managed care operation, and then we run those panels against the ENS notification and try to cone down to the people that we really can help. And then the other thing we do is, instead of giving the primary care physicians all of the information that we got, we only give them the actionable stuff in one list, and then all the stuff in another list in case they're interested. And that phone number is really important, because the primary care doctors will tell you too that the phone numbers that they have, the phone numbers that we have, are not the same phone numbers that the person has. So that's been very helpful. We've only been doing this since the beginning of May with the ENS, although I've been anxious to do it since I first heard about it. And I was really glad when all the hospitals finally signed up, because at first, none of the hospitals wanted to go first. And so we waited and begged and waited and begged, and then when it went statewide, it became a really valuable resource.
And if I could just add on to that, I mean, what Dr. Preston just nailed it. That is that's the feedback I get from everybody that uses the ENS service, is that it's great. We'd love more diagnoses. And the thought process, and two things, it's a lot of data, it's a lot, and it's tough to triage right now, no two ways about it. We will be working in the future to incorporate, in the near term future, some things to ease that triage, that task. And the two things is we have diagnosis codes or descriptions from about a third of our data sources. We're going to be working on getting the rest incorporated into the service. And then what we're also going to be doing is adding another data field to the notifications to say how many prior admissions that person may have had in the past 6 months. It's an arbitrary time frame, whatever works. And so that again, and this is just an Excel spreadsheet. You can sort every column you want, so you can go find the diagnosis codes that jump out at you. You can sort based on the the prior encounters and see who your super utilizers are. And so we know that's going to make it a lot better. With the reason we didn't try and do that at the outset is, again, we wanted to instill confidence in the service on behalf of the data sources and not make it an all or nothing thing. And we know the power of just the phone number. So let's get that rolling, and then we'll work on building it out and making it more usable, more consumable.
And they've been very cooperative. I mean, this has been a pretty easy implementation, and those things never go easy.
It's deceptively easy, yeah.